Here's our newborn care flow chart. Newborn care is usually quite simple, and in every case, our primary goal is to keep that infant from getting cold. If we can keep him warm, then things will go good for us. So one of the first things we need to do is dry him off. Now he will be covered in vernix, kind of a cheesy sort of paste, lubricant, and we're never going to get all that off. That's not the goal. The goal is to get wet fluid off of him and keep his head covered, rub his back, stimulate him, and keep him dry and warm. So we're going to dry him with one towel and then replace it with something dry. Wrap him up, cover his head, not his face, and almost all these little guys will take off breathing, hopefully screaming. We want crying, screaming babies. That means they have great airways and good lungs, and that will usually happen. We'll give them 30 seconds to start crying and really react to us drying them off. During that time, we can add some suction of the mouth and then the nose. That may have already occurred as the head emerged, but it's another good thing for us to do to stimulate. We don't want to mess around too long, so about 30 seconds of drying, maybe some quick suctioning, and then we need to assess. And what we're assessing when we come to this diamond, this decision point on our flow chart, we need to know, is he crying and breathing, and is his heart rate greater than 100? Or is he over on the other side here where he is just gasping or he is apneic, he's not breathing at all? If he's gasping and apneic, not breathing at all, and we haven't already, then we must clamp and cut the cord, and we're going to need to do some things. If he's crying and breathing, but it's kind of a weak cry, and his heart rate is not above 100, then we're also going to need to clamp and cut and start doing some resuscitation. Now, we'll always need to dry and warm the infant. We'll always need to do some suctioning. We won't always have to do anything else. And if he's crying and breathing normally, his heart rate's over 100, things are good, all we have to do is keep him warm and things will be okay. If, on the other hand, he's gasping or apneic or his heart rate is less than 100, then we're going to need to ventilate him. Now we'll use a bag mask for ventilation, and we'll ventilate him for about 30 seconds at a rate a whole lot faster than normal, a whole lot faster than for adults. Our ventilation rate is going to be between 40 and 60 breaths a minute, so not quite once a second. And the amount of air he needs, his tidal volume, is quite small. We're talking 30 cc's perhaps. So, I mean, just imagine a 20 or 30 cc syringe. We're not talking about very much volume here at all. And we're going to ventilate him with small volumes at a pretty quick rate, just less than once a second, for 30 seconds, while we're keeping him covered and warm. Then we're going to reassess again. Again, we're looking for, is he breathing? It's not his breathing rate, it's is he breathing, is he crying? And then is that heart rate greater than 100? And usually, if we've had to ventilate the child, that's all it's going to take, and his heart rate's going to be greater than 100, it's going to be crying and breathing, and now we're in to keep him warm and everything's cool. On the other hand, if he's breathing but his heart rate's less than 100 or he's not breathing, then we're going to continue our ventilations with that same small volume, pretty fast rate, and we're going to add compressions. This is the only time in the universe when chest compressions are not 100 times a minute. They are 120 times a minute. 2 compressions per second in a ratio of 3 to 1. So you do 3 compressions, 1 small breath. 3 compressions, 1 small breath. And we're going to do that for 30 seconds. So we're going to give him some compressions and ventilations in an attempt to support him and get him going. We're going to do that for 30 seconds and then reassess again. Reassess again. So it's not a full 2-minute interval right off the bat like we usually do with adult codes. In this case, we're going to give him a 30-second trial of ventilations, check him again. If we need to, heart rate's still not greater than 100, we're going to add compressions at a rate of 120, so 2 per second, and a ratio of 3 to 1, 3 compressions, 1 small ventilation. We're going to do that for 30 seconds. Reassess again. Now this is a three-way branch off this diamond, off this decision point here. There's one of three things that can be going on. What we're hoping for, goodness, we're hoping for heart rate greater than 100, he's crying, he's breathing, everything's good. That was a close one. We had to do a few compressions, but now we just keep him warm and keep watching him, and things are going to probably be all right. It might be that his heart rate is still a little bit on the slow side. He's between 60 and 100. In that case, we're going to go back to ventilations and then keep reassessing. Give him another minute and try. But if he's less than 60 on the heart rate, then things are not good. The usual just need to wake him up and oxygenate him a little bit's not working, and now we're into pretty much a full-on code. And now we're doing compressions and ventilations at the 3 to 1 ratio, and we're into a standard 2-minute interval cardiac arrest. For the medics now, you're going to add an IV or IO, probably an IO in this case, umbilical cord vein cannulation if that's in your protocol. That's where the IV fits in there. And then a very tiny dose of epinephrine. Again, it's Flowchart, it's the usual cardiac arrest stuff. Intubation pretty early on, but we're trying to get the epi in. We're not trying to get him an airway as much as we're trying to get the epi in. And so that's what's going on there. Okay? So overall, dry and warm, that will take care of business most of the time. A little bit of suction won't hurt. Most of these guys will be just fine. They'll be crying and breathing. They'll have a good heart rate. Just keep them warm. Sometimes they're gasping or apneic and they're just not waking right up. Clamp and cut if you haven't already. Do some ventilations for 30 seconds. Check. If you need to, add compressions for 30 seconds. Check. And then in that very rare case, then it becomes a full-on code. And then you revert to what you usually do. Last note I wanted to make was, how do you check the heart rate? Well, this is not that brachial pulse check that comes from American Heart CPR for infants. This is a newborn. Newborn is different than infant. Newborn, his age is measured in seconds or minutes. His cord has barely been cut. And so he has different rules. And the best way to palpate a pulse in the newborn is at the base of the umbilical cord, where the cord and the baby meet. Right at the base there, you can usually feel, and you know what the rate of 100 is. 100 is your adult CPR rate. Everyone knows that in their head. Whether you're singing Staying Alive or something else, you know what that is. And so 100 is a good benchmark for us. And that umbilical cord pulsation is an excellent way. The other way you can do it is your stethoscope apically, so you're listening for that heartbeat over the apex of the R, right where you see the maximum impulse there. But the palpating the pulse at the base of the cord works great. So again, it's not about his breathing rate. With adults, we ventilate based on a poor rate or poor depth or excessive effort of breathing. It's not about that for newborns. It's about their heart rate. It's all about their heart rate. Infants or newborns that get in trouble, whether they're still in uterus or have just been born, they get bradycardic. And so we're looking for a rate of greater than 100. If not, we're going to ventilate a little bit. If that doesn't help, we're going to add some compressions for a little bit, and usually that will help. If not, then we're into a full-on code. So that's our flow chart for newborn care.